Question 70. Which of the following best explains the mechanism of disease in this patient? Dysfunctional ciliary movements, chronic allergic airway, defective chloride transport. Okay, so this is a respiratory question. A 36-year-old man presents to the clinic for evaluation of shortness of breath that has progressively worsened over the past 2 years. He reports difficulty climbing stairs and keeping up with his coworkers. He denies fever, sputum production, chest pain, or peripheral edema. He smoked a half pack of cigarettes daily for 5 years, but quit a decade ago. Okay. So he's got a 2.5 pack year history, but he still quit a decade ago. His father died in his 50s due to alcoholic cirrhosis. Okay, so he must have been a serious alcoholic who died in his 50s. Physical exam reveals diminished breath sounds bilaterally. Pulmonary function testing shows a decreased FEV1 and increased total lung capacity. So decreased FEV1, increased total lung capacity, definitely some lung disease. Chest x-ray reveals hyperlucent lung fields, most prominent at the lung bases. No interstitial markings or masses are seen. So let's start with what type of lung disease it is. Pulmonary function tests are great at helping you figure out the type of lung disease. So if we have decreased FEV1, does that help us eliminate either obstructive or restrictive lung disease? No, probably not, because they both have decreased FEV1. Obstructive just has much more decreased FEV1. What about increased total lung capacity? I think this one is a little more indicative. If we are increased total lung capacity, that points at signs of obstructive lung disease with air trapping, as opposed to restrictive lung disease where you have trouble filling the lungs, so your total lung capacity might decrease. Obstructive lung disease, the problem is getting air out, so you get stuck with extra air, therefore your residual volume and your total lung capacity increase. So we're probably talking about an obstructive condition here. So let's go through and just cross off anything that's not obstructive right away. Dysfunctional ciliary movements in the airways. Actually, you know what? Why don't we start by labeling these? Dysfunctional ciliary movement in the airways. So dysfunctional ciliary movement kind of sounds like a chronic bronchitis. Something preventing the cilia from working would be chronic inflammation of the bronchi, which are where you're going to see a lot of cilia and mucus cells. Chronic allergic airway inflammation. Is this asthma? This one's asthma. Defective chloride transport. This one we should know right away as cystic fibrosis. Increased deposition of extracellular collagen is an interstitial lung disease. Deficiency of a protease inhibitor is probably referring to alpha-1 antitrypsin deficiency, A1AT. Environmental antigen exposure could be a hypersensitivity pneumonitis if it's an organic antigen, or it could be a pneumoconiosis if it's an inorganic antigen like silica or asbestos. All right, let's get the slashing. Which one of these are not obstructive lung diseases? Let's see how you do here. So pneumoconiosis and hypersensitivity pneumonitis, these hypersensitivity reactions result in damage to the interstitial space. Interstitial space damage and scarring, fibrosis, that's all a form of interstitial lung disease, which is restrictive. A1AT deficiency, essentially a form of COPD, especially in young people. So this one should be high on our list right now, but definitely obstructive. Interstitial lung disease, again, this is, as it says here, deposition of extracellular collagen. This is outside of the cells. It's going to be restrictive. So cystic fibrosis, remember there's a ton of really sticky mucus that you can't get rid of because of the defective chloride transporter. This mucus gets stuck in the small airways, which causes bronchiectasis. And bronchiectasis is a form of obstructive lung disease because you can't get air through these really stenotic airways. So this is obstructive. Asthma and chronic bronchitis are essentially the same thing, just from different causes. They're both obstructive lung diseases, narrowing of the bronchi. Okay, so we were only able to eliminate 2. But at least now we're thinking E might be a solid option. Let's start from the top. Chronic bronchitis is a form of COPD classically associated with chronic exposure to smoking. This guy has a 2.5 pack year smoking history. So there's no way he has chronic bronchitis from COPD from a smoking history. Plus, chronic bronchitis is associated with bountiful sputum production, and he denies sputum production. Also, we would expect to hear wheezing with chronic bronchitis, which which we don't have, because wheezing is those narrowed airways, right? If we got our bronchial tree here and we got some narrowing as the air rushes past this, it becomes essentially turbulent. You can think of it like a murmur. You get this turbulent airflow which vibrates the bronchi, and that causes our wheezing. So this one's out. Same thing with asthma. We'd expect wheezing. We don't have that. What about cystic fibrosis? Cystic fibrosis is more of a multi-system process. It usually presents with many other symptoms at the same time. Not only would you expect to see lung infections frequently because of the bronchiectasis, but you'd probably also see GI symptoms. So that one's out. And just like that, we've ruled it down to E, protease inhibitor. Even if you didn't know what that was, I think you could have gotten to it if you had known everything else. You need to know something. That's the rule of thumb. But alpha-1 antitrypsin deficiency doesn't make sense here. Well, his dad died in his 50s from alcoholic cirrhosis. Sure, it's possible he was just pounding Bud Light every day, and that's what killed him alone. However, if his dad also had alpha-1 antitrypsin deficiency, then his liver would have been particularly prone to damage. So he might not have even needed that much alcohol to get to this point. Same thing with the lungs. Alpha-1 antitrypsin affects the lungs and the liver. So this guy with just a 2.5 pack year smoking history, that could be enough to trigger the onset of COPD when he has all these defective proteases that are going haywire, destroying the lung tissue. Add just a little insult from the smoking, and that can be all you need to get full-blown COPD. So that's why the correct answer is E.